a pretty low incidence of hyperkalemia, which is the most worrying complication of starting somebody on spironolactone. And it's suggested that, one, the patients weren't representative of real patients, and number two, if you're in a clinical trial, you're extremely well supervised. You know, you're getting paid by a big drug company to supervise the patient much, much better than is done in real life. And there's quite a lot of work after the RALS trial, when spironolactone started to be dished out quite a lot, that showed that lots more people than the trial suggested got dangerous and sometimes fatal hyperkalemia. So I worry in frail old people who've usually got some renal dysfunction as well about giving them spironolactone. That's number one. Number two is that it fundamentally is an add-on drug to help prognosis. It can sometimes help symptoms, but its prime, in the study, the prime reason for its use would be to reduce mortality and reduce hospitalization. And I'm not always that convinced that that's what I'm really trying to do with frail older people. If I can make them feel better, I'll stop at that. Or I'll speak to them and I'll see what they want to do. If I say to them, do you want to take another couple of drugs that might make you live longer? And they say, yeah, I'll give it a go, then we'll try. But I would usually draw a line at the drugs that have made the person feel better, rather than loading them up with lots of other agents, including eplerenone.
In older people, when we plan a rehabilitation program for them, is heart failure ever a contraindication? And what should we do to kind of screen and prepare for it when we start rehabilitating older people, because they do have other problems as well?
Yeah, I don't think it's ever an absolute contraindication. I mean, in lots of things you do in rehab, you've got to listen to the patient and pace what you do at what they're able to do. And obviously a patient with heart failure may not be able to go through a specific routine that the physios would otherwise like them to do. We get a wee bit perplexed these days in our wards with the use of oxygen saturations. Yeah, so the physios will be measuring saturations when the patient exercises, and they'll come back and say, oh, we got them up to do their walking today and the sats dropped to 91, so we've put them back in their chair. And you say, well, how did the patient feel? And they were fine. So I said, well, just try and ignore that number a little bit more. So I would base it on how the patient feels rather than a measurement.
If there are no more questions, before I give it to my colleague to close the session, a comment on the lighter side. He showed the gentleman running 100 meters. There's an Indian called Fauja Singh, who is 100 years old. Yeah. He runs the London Marathon. And then when he wanted to have himself enrolled in the Guinness World of Records, they asked him to produce a birth certificate. 100 years ago, it was unknown, something like birth certificate. So they refused to enter him in the Guinness Book of Records. This is for your information.
Thank you, sir. I think you're the right person, because your name itself is elder. So you talk the right person, right place, because nowadays the older population is slowly and steadily increasing in number. Not only in India, you name any part of the world actually. In fact, they are replacing the younger generation, because younger people are dying more in number because of the RTA and so many accidents. You name any accidents, because younger people are very rash and other things. So they die more in young actually. So we are getting a steady increased population of elderly people. So this is the right person. Of course, elder is the right person, and right place also, and right time also. He comprehensively talked about the heart failure, and it's very difficult also to diagnose it, because we didn't go a set of criteria which we use in the normal younger generation, because as I told, atypical symptoms actually we can call it as heart failure equivalence. For example, depression. The people, as you told, madam, yeah, it's well taken actually. If you have to take care of the depression, anemia, because they're all what I call a non-significant, it's not a typical pattern of heart failure. So we have to take care of the patient, as Dr. Elder told correctly. We have to look at the patient as the patient himself in total, not isolated heart diseased patient, as cardiologists used to do. So ideal person is a physician which sees the patient as a total person and analyze it, and we have to give a comprehensive health care. And as rightly pointed out, the treatment doesn't going to change the prognosis. We may improve the quality of life. That is what actually the Lord God has sent us to give a better quality to the patients rather than treating the disease completely and eradicating. That may not be possible in all the cases. So we have had to see what are the comorbidities, take care of the comorbidities also. As one point, actually, if you take the patient, make him happy, maybe his heart failure also may come down. He may have a very good quality of life. That's what the ultimate aim. So again, we thank you, Dr. Andrew Elder, for a very wonderful and very illuminating speech on the heart failure, and really we carry your messages to our home. Thank you. Thank you very much, sir.
Thank you, Chairman. Thank you, Dr. Elder. May we request now the Chairman to present a memento to Dr. Elder. Just a minute. May I request Dr. E.S. Krishnamurthy to distribute the certificates to the chairpersons. Dr. Dandabani, Professor of Medicine, Madras Medical College. Dr. Subramaniam, cardiologist. And now we adjourn for coffee. We should be back by 11 o'clock. Thank you. Please, those of you who have finished the coffee, please assemble over the hall. We are starting the second session of today. The chairpersons are going to be Dr. Kamakshi Shenbog and Dr. Muttarasu. Dr. Kamakshi Shenbog is a well-known professor of neurology, former head of the Institute of Neurology, MMC, and she did her MBBS from Stanley, MD from Stanley, DM from MMC, and awarded FRCP Edinburgh in 2011. She's got number of publications over the Neurological Society of India, World Congress of Neurology, Indian Academy of Neurology, and she's won a lot of number of prizes, all starting from first MBBS, and got gold medal in medicine, social, and etc. It is beyond the scope of this my talk to cover up all our achievements. And I request her to come on to the dais. Yeah, please. Yeah, yes.
You want me to sit down?
Yeah, sit. And Dr. Muttarasu is Professor of Neurology, Institute of Neurology, Government General Hospital, Chennai. I request him to come over to the dais. Hello, sir. Please come. The topic is going to be dizziness and collapse in old age, diagnosis and management. I request the chairperson to take over and do the proceedings.
I thank the organizers for giving me this opportunity of chairing such an important session. And I am delighted to chair a session where Nikki College is speaking. Although I have met her only recently, she swept me off my feet, as the expression is. She's a lady who's so highly talented, and I will read her biodata, which is mind-boggling, but should be an inspiration for youngsters in this audience. One day, we hope that all of us could achieve this type of biodata. She's a consultant physician in medicine of the elderly, honorary senior lecturer in geriatric medicine, University of Edinburgh, UK. And please hold your breath. She's the Dean of the Royal College of Physicians of Edinburgh. Such a humble, I wish you could clap for that, yes. Such a humble, unassuming, wonderful human being. Nikki, I'll call her Nikki, graduated with honors from the University of Edinburgh in 1984 and trained in and around Edinburgh. Her current consultant post entails acute and rehabilitation in patient care and a day hospital work and general work. She has interests in Parkinson's disease and has a Parkinson's disease clinic. Special interests include dizziness and collapse, which is the theme song of today's lecture. Parkinson's disease, falls, and fracture prevention. She has a particular interest in postgraduate training and as a past secretary of the Specialist Advisory Committee in Geriatric Medicine, was part of the team who wrote the first UK curriculum for specialist training in this specialty. Again, I'm proud, very proud, as a lady, she's now the Dean of the RCP. The overseas and the colleges can be accessed from anywhere in the world, and symposia are now being web streamed in the 5 fellows of the college as possible. She also represents the RCP on the Joint Royal Colleges Postgraduate Training Board, which is responsible for setting curricula and assessment standards in the medical specialties in the UK. She's an editor of Davidson's Principles and Practice of Medicine, which is used by all of us, medical students, teachers, professors all over the world. Actually, it is our basic guideline. She's spoken at medical schools in Delhi, Bangalore, Mumbai, Pune, and now in India. Such a mind-boggling and such a wonderful biodata. I think we are extremely privileged and honored to have such a great lady in our midst. Ladies and gentlemen, please give her a huge applause. She is going to speak about dizziness and collapse. And I presume she would be dealing with arterial narrowing, arterial thickening, diabetes mellitus, hyperlipidemia, and basilar vertebral thickening, top of basilar. You have nearly 100 neurological causes. And it all depends on how Nikki is going to deal with it. I'm sure it will be very highly special to all of us. I just want to say one thing. Sometimes myoclonus can also be a cause of a collapse. You can have a positive myoclonus or you can have a negative myoclonus. And during the process of negative myoclonus, you drop. So these are one of the few causes. And I hand over the mic to Nikki. And it is already there.
Thank you.
And I'm anticipating a wonderful bonanza from her. Thank you very much. Thank the organizers for asking me to and my colleague to chair. Would you like to say something?
It's okay, madam. Well, I'm a little overwhelmed by all that, but thank you very much indeed, Dr. Shadabog. I'd also like to just take this chance to say a few thank yous to other people. First of all, obviously, to the Indo-British Health Initiative, VHS, and the Indian Neurosciences Group for inviting us all the faculty from the Royal College of Physicians to participate in what has been a really marvellous meeting. Very much appreciate that. I'd like also to thank some of the people behind the scenes. In fact, behind me, Ms. Namala Vani, who's done a wonderful job organising our stay here, absolutely supreme efficiency, along, of course, with Lalita Ray. Obviously, all the venue staff, the projection staff here have done a fantastic job. Very, very impressed. And obviously, Dr. Krishnamurthy, what can I say? He's organised this whole meeting. It's been absolutely marvellous, very much appreciated. He and his wife have shown us great friendship and hospitality, and we've really enjoyed our stay here in Chennai, largely through his efforts, so I can't thank him enough. Finally, I'd like to thank all the chair people that have participated in the meeting. I think they've done a very good job, but also particularly the audience, yourselves. You've given us such a lovely welcome. You've been interested in our talks. You've asked some great questions and talked to us in the breaks, wanting even more information. It's been a really fantastic experience to be here. And I just hope that we can continue the relationship with you, perhaps taking forward your future healthcare plans for older people. I've just been told that today is in fact Senior Citizen Sunday in the Church of Southern India, so it seems very appropriate that we're all here to talk a little more about what we can do for their health. So from all that, I'm going to go to dizziness and collapse and old age, and I think many people look at this and think, oh, help, where do you start? And this was summed up very beautifully by a British physician called W.B. Matthews, who said, there can be few physicians so dedicated to their art that they do not experience a slight decline in spirits on learning that their patient's complaint is giddiness. And I think that rings true with us all. But why is that? Why do we feel so gloomy when a patient says they feel giddy? Well, I think the first reason is that there's a whole multitude of potential causes for dizziness. I assure you I'm not going to go through all of these in detail, or we'd be here till tomorrow. Many of them are difficult to diagnose, and many of them are difficult to treat. Acute dizziness is relatively straightforward. It can occur in the context of sudden hypotension, perhaps due to an acute cardiac event, or a sudden hemorrhage, GI bleed, or pulmonary embolism. It can also occur in the context of hypoglycemia, most commonly related to the treatment of diabetes. In older age groups, you would consider the possibility of a posterior circulation stroke, whilst in younger people, you might think about an acute labyrinthitis or vestibular neuronitis, or possibly a first attack of Meniere's disease. But the much more challenging problem are the chronic symptoms, the chronic episodic symptoms, and that's what I'm going to concentrate on in this talk. So the first tricky bit is for patients to describe exactly what they're feeling when they are dizzy. It's a very hard symptom to explain often. If you stare at this for a minute or two, try and put into words the horrible feeling that you've got. It's not easy. So the result of that is that patients will come out with all sorts of extraordinary ways of describing their symptoms. And these really are not very helpful. My absolute worst one is, I'm just not right, doctor. I'm dizzy, I'm just not right. Now, where do you begin to sort that out? Or even worse, possibly, although I smile at this one, I just feel queer. So right from the beginning, you think, oh, hell, what am I going to do with this? But most of these symptoms will fall under one of three categories, if you like, of symptom. The first being vertigo or a sensation of movement. The second being one of lightheadedness or perhaps feeling faint. And the third, a sense of imbalance or unsteadiness. And it can often help patients if you offer these as possible descriptors of their symptoms when they're struggling to explain how they feel. And that then helps you decide on the best approach to their further assessment and management. So what I'm going to do in this talk is I'm going to take each of those three categories of symptoms and talk about the different causes for each and how you can differentiate between those and manage them. And then I'm going to set myself the ultimate challenge to talk about what you do with a patient that presents with all three at the same time. So first of all, vertigo. Vertigo is obviously the sensation of movement. It can be caused by problems in the inner ear or within the brain stem. So it's important to ask about hearing, any changes in hearing, and whether the patient has any associated neurological symptoms, because that then helps narrow things down between these three principal causes of vertigo almost at once. Benign paroxysmal positional vertigo is not associated with any hearing change or neurological symptoms. Meniere's disease, on the other hand, is associated with hearing loss, whereas a posterior fossa lesion, which is much the most commonly due to a vascular cause, will have other related neurological symptoms. Space-occupying lesions, such as a cerebellopontine angle tumour, are really quite rare, obviously have to be considered, and demyelination is extremely rare. So, first of all, let's talk about benign paroxysmal positional vertigo. Now, this is a condition in which the lining of the utricular macula, which lies in the inner ear over here, becomes degenerate. And as a result of that, little otoconia, which are in this slide here, are released into the endolymph of the semicircular canals, and as a result of gravity, most commonly settle at the bottom of the posterior semicircular canal. And what happens is, whenever the head is moved, those little otoconia set up turbulent flow within the endolymph, as a result of which the patient will experience a brief episode of vertigo. Now, this condition can be idiopathic. It may occur after trauma to the head, and it may also occur following a viral infection or be due to ischemia. It becomes much more prevalent as patients age, and often what they describe is very quite classical. They particularly complain of a sensation of movement when they turn over in bed. There are not many other conditions that do that. These are patients who say, I have to lie on one side. If I try to turn to the other, I get this terrible vertigo for a few seconds. Sometimes they also get it when they get out of bed in the mornings. As I've said, there's no hearing change, there are no neurological symptoms. The vertigo is very brief and they feel entirely well between times. So if you hear a history like that, your next move is a Hall-Pike test. A Hall-Pike test is done by sitting your patient on an examination couch, turned to face you. You then lower them down so their head is hanging over the end of the couch, and you instruct them to keep looking at you and to keep their eyes open at all times, because what you're looking for is that classical sign of torsional nystagmus. Once seen, never forgotten. Those of you who yesterday will have seen the little movie clip that Dr. Davison showed of that. You then sit the patient back up and walk round to the other side of the couch, get them to turn to look at you and do exactly the same again. And that way you won't miss the diagnosis on either side. But it's important to be quite clear what you're looking for. It's not just about nystagmus. You're looking for a brief lag period before it begins. Then usually what happens is actually the patient shouts, that's the symptom that I have. They feel really unwell and they get terrible torsional nystagmus at the same time. It generally lasts less than a minute and then disappears. If you sit the patient back up, they'll sometimes have symptoms again, and you may see the torsional nystagmus, but in the opposite direction. If you repeat the test, you'll find they still have some symptoms of vertigo, but they're much less prominent. Now, this is all important because it helps you differentiate benign positional vertigo from a central lesion. In central lesions, there'll be no lag period. The vertigo may be mild or absent. The nystagmus may be vertical or change direction. And it will last as long, generally, as you keep the patient in that supine position. If you repeat the test again, it doesn't fatigue. The nystagmus remains very much the same. Now, if you do find the characteristics of benign paroxysmal positional vertigo, it's very satisfying because you can immediately go on and cure it. There's not many conditions you can say that of at a clinic appointment. And the way you do this is by performing something called the Epley manoeuvres. Now, the underpinning mechanism to these, the manoeuvres cause the otoconia that I mentioned floating about loose in the endolymph to drain into the endolymphatic sac. So you start off just by doing a straightforward Hall pipe maneuver to the side that was positive when you did the original test. You wait for the patient's symptoms of vertigo to subside and then hang on in that position for another minute. You then turn their head across to the other side without sitting them up between time. You're just turning their head so they're facing the other way. And once again, you maintain them in that position for a minute after any symptoms or vertigo have settled. You then explain to the patient you want them to keep their head looking over that shoulder, but you want them to turn to lie on their side. So they're going to end up lying on their side looking at the floor, something like this. And once again, you hold that for a minute, and then you ask the patient to swing their legs over the side of the couch and sit up on its edge. You bend their head forward so they end like this. And that's all there is to it. It's very, very simple. You should advise the patient to try and keep their head up over the next 48 hours. So that includes when they're in bed, try and sleep propped up. If they drop something on the floor, get the partner to pick it up, or just leave it until the 48 hours are up. As I say, extremely satisfying. You'll have very grateful patients if you can master this very simple technique. So the second condition I want to talk about was Meniere's disease. The pathophysiology of this isn't very clear. It's associated with unilateral dilatation of the membranous labyrinth. And in this condition, the hearing is also involved. Patients will gradually lose hearing in the affected ear and will also have tinnitus and a sense of pressure within the ear as well. The vertigo once again occurs as attacks. This can be very variable in duration and very variable in severity. At worst, it may be associated with very severe vertigo that quite prostrates the patient, be associated with nausea and vomiting. The diagnosis is made with audiometry and electronystagmography, and the treatment really has 3 prongs. First of all, you want to prevent the attacks, and that can be done. Some evidence to show that low salt diets, diuretics may help. You should advise the patient also to avoid caffeine. Acute attacks can be aborted to some extent with sonarazine. But as the condition develops, many patients lose hearing in the affected ear and develop more and more severe vertigo, such that it is quite disabling. And then you have to really consider referral to an ENT colleague to look at some form of surgical lesion to the vestibular nerve to destroy it, because it no longer really has any useful function if hearing's been lost in that ear. And that can be achieved with intratympanic gentamicin or a more formal vestibular neurectomy. So the other thing, as I've said, has to be considered is actual brainstem disease. But it's fairly rare. And I would only image people who have convincing neurological signs with their vertigo, perhaps in association with vascular risk factors, or indeed those with that atypical Hall-Pike response that I mentioned that suggests the possibility of a central or cerebellopontine angle lesion, such as an acoustic neuroma, as you see in that MRI. And just to highlight the rarity of these lesions, I've quoted a study here that found that if you scanned everyone that presented with vertigo, you'd have to do 2,500 scans to identify one person with a cerebellopontine angle mass. And even if you screened out and just scanned those that had vertigo and asymmetric hearing loss, you'd still have to do over 600 scans to find one cerebellopontine angle lesion. So, as I say, if you see a patient with vertigo, you should not really be requesting an MRI scan unless you're very convinced that there are neurological features associated. Okay, well, let's move on from vertigo to lightheadedness and syncope. And this is where collapse, I guess, comes into the talk, and that many of the pathologies I'm going to discuss can also cause syncope. It'd be quite a challenging symptom to sort out. You see the principal causes here: anxiety, structural heart disease, arrhythmia, the neurally mediated syndromes, and cervical OA. And I'll talk about each of these in turn. So anxiety is the most common cause of dizziness in people aged under 65, but obviously may still occur in older people as well. It's a very common, if you like, comorbidity in people with other causes of dizziness. Patients will often describe tingling in their fingers and around their mouths in association with it. And it's often associated with hyperventilation, which is very useful because you can actually demonstrate that it's the cause to the patient by actually asking them to voluntarily overbreathe while you're seeing them in your clinic. Getting them to breathe as hard and as fast as they can, and it will bring on their usual symptom, and it kind of wakes them up to the connection as well. Most patients are helped through education with relaxation and re-education techniques, and medications really only very rarely required in the most severely affected, perhaps with an antidepressant, or even with a non-selective beta blocker like propranolol. Cervical osteoarthrosis causes dizziness as a result of joint proprioceptor damage. And I think now the term vertebrobasilar ischemia, as we discussed yesterday, is becoming somewhat obsolete as we have MR angiography to show that many normal older people have narrowing or blockages in their vertebral arteries and yet don't have any dizziness at all. And those abnormalities are just as prevalent, if you like, in the non-dizzy elderly population as the dizzy. So cervical OA is now thought to be the more likely mechanism for dizziness on neck movement and head turning. And patients often describe a sensation of trying to close the curtains, putting their head back and feeling very, very dizzy, or hanging out washing as another one. They put their head back, feel very, very dizzy. It's never associated with syncope, which is an important discriminator from one of the neurally mediated syndromes that I'll talk about in a minute. As I said, it's again easy to demonstrate clinically just by asking your patient to make the head movements that bring on their symptom. And this is where our physiotherapy colleagues can be very helpful in that the best treatment is to try and mobilize the neck muscles. And I think also a lot of that, the physiotherapy helps to habituate the patient to their symptoms on head movement so they become less distressing. So the next set of causes are the, if you like, structural heart disease. And the main ones to think about are lesions that cause outflow obstruction, such as aortic stenosis and hypertrophic obstructive cardiomyopathies. I put pulmonary embolism in brackets there because it's more a cause of an acute dizziness than chronic episodic dizziness. The symptoms of lightheadedness and sometimes syncope here will occur mostly on exertion and may be associated with chest pain. And beside that, as you see, you've got an echocardiogram which shows a horribly stiffened and thickened aortic valve in systole that doesn't open at all when you compare it to the normal aortic valve. It's important to remember, though, it's not just outflow obstruction, and that severe coronary artery disease can equally cause lightheadedness and chest pain on exertion. So don't forget that may also be present. Obviously, the other cause often springs to people's mind is the possibility of an arrhythmia. And again, these may cause lightheadedness, sometimes syncope as well. They may occur on exertion, but in fact they can occur at any time. The patient may even have their symptoms at rest, which again is quite a useful discriminator, and there's not many other causes that would do that. Patient may or may not have palpitations and chest pain in association, but you should always do an ECG, I think, in every patient with dizziness, in fact, because it can be very helpful if the patient is in sinus rhythm when you see them to identify the possibility that they may be having a dysrhythmia. And just put a list here of some of the suspicious findings that you would want to be looking out for that would provoke you to go forward to do a 24-hour ambulatory ECG. And clearly there are a huge range of possible arrhythmias that may be associated with these symptoms. And I've just put up a couple of examples here: sinoatrial disease, sinus arrest, sinus brady, atrial fibrillation, or occasionally complete heart block. But, and it's a big but, ECG abnormalities are only important if they coincide with symptoms. I think John Davison mentioned yesterday, we know that about 15% of older people will have asymptomatic arrhythmias on a 24-hour ambulatory ECG, which doesn't cause them any symptoms at all. So unless the ECG abnormality coincides with an episode of the patient's symptoms, it's not important. And this can be a real challenge because the chances of an arrhythmia that's perhaps fairly infrequent, fairly short-lived, occurring during that 24 hours that you have the ambulatory ECG on are pretty small, and why increasingly we have to resort to using implantable recorders or patient-activated recorders, which you can continue monitoring for up to a year. So next I would like to talk about the neurally mediated causes, and these are syndromes in which, if you like, there's damage or abnormalities in the autonomic nervous system which affect the control of the pulse rate or blood pressure. And there's quite a range of them. As you see, postural hypertension, we obviously discussed a bit during John Davison's talk about falls. There's also vasovagal syndrome, carotid sinus syndrome, postprandial hypotension, and some of the situational symptoms that are probably fairly easy to diagnose because they so obviously occur related to these circumstances. So fear, very common ones with patients, are the sight of needles, sight of blood, straining at micturition in older men with prostate problems, prolonged coughing in people with COPD, straining at stool in people with constipation. Prolonged sneezing can cause it very rarely, and also attempting to swallow a large food bolus does on occasion cause syncope. I'm really going to concentrate on the first three in that list, as I feel the rest are fairly obvious. So postural hypertension, I think John again defined this yesterday. It tends to correlate rather poorly sometimes with patients' symptoms. It becomes much more common with old age. And it shouldn't be dismissed because it is associated with significant morbidity such as falls and stroke, and indeed an increased mortality. I'm not going to talk about how specifically it's diagnosed with monitoring, as I think John covered that very well yesterday. But it is important to think about other exacerbating factors. Not a lot you can do about aging, but dehydration, cardiac disease, medication, I put it in red because it's such an enormous problem in old age and such a common cause of postural hypertension, and anemia. The rare underlying conditions to think about would be a diabetic autonomic neuropathy, Addison's disease, or possibly multiple systems atrophy. How do you treat it? Well, obviously the first step is look at their drugs. I think this has been a theme, if you like, throughout many of the talks, the harm that medication can do patients. That's a huge long list there. I like just to remember anything that could be construed as belonging to a group of anti-drugs you have to look out for. So anti-anything is likely to cause postural hypertension. Other practical things you can do are to suggest to the patient they tilt up the head of their bed so they've not got such a long way to stand, particularly first thing in the morning when symptoms can be very bad. Graduated compression stockings can be very helpful. I would have to say in the very elderly and frail patients, they find them almost impossible to get on, and you don't want to be inducing falls as a result of trying to put on compression stockings, which would be a bit of a sad irony. Make sure your patient's adequately hydrated. Many older people seem to lose their sense of thirst, and it's very important to try and persuade them to drink at least 1.5 litres, 2 litres each day. Drugs are really our last resort here, and I'm sure you're all aware of how difficult it is to use NSAIDs in old age, not least the gastric side effects, also the problems with kidney dysfunction. You can use fludrocortisone at very low dose. It has the effect of causing, just at low dose at least, mild salt and water retention, which may help. Midodrine is an alpha blocker, which again can be used, but in my experience is very poorly tolerated in old age and makes people feel really quite unwell. So what about vasovagal syndrome? Well, John and I were discussing this last night and saying essentially it's a posh word for fainting. And I'm sure you're all familiar with the triggers for it. Prolonged standing is the classic, particularly if it's in a warm atmosphere, if you have any underlying systemic illness, if you've just eaten a large meal. And patients will often complain that just prior to their syncopal episode, they feel nauseated, they sweat, and any witness will describe them as being extremely pale. Patients will be more susceptible to it if they're on particular drugs, ACE inhibitors, long-acting nitrates, calcium channel blockers, or diuretics. You can, I have to say, mostly it's diagnosed from a good history, and it's very rare you would resort to a tilt test to prove the diagnosis. But this can be done. It involves lying the patient on a tilt table with blood pressure and ECG monitoring continuously, and then tilting them up to 70 degrees for 40 minutes. There are three possible responses in vasovagal syndrome. Firstly, a vasodepressor response in which the blood pressure falls to less than 80 or by 50 millimeters mercury. A cardioinhibitory response in which you see a bradycardia to less than 40 or indeed complete asystole, or sometimes you see a mixed response to that. But once again, treatment largely hinges around avoiding the things that provoke it, so trying to avoid standing for prolonged periods, not eating very large meals, and once again, trying to persuade the patients to maintain an adequate fluid intake day to day, withdrawing the culprit medication. And you can also teach them what are called counter pressure measures. And these they can do as they feel those warning symptoms of nausea and sweating. So things like isometric hand grip, arm tensing, and leg crossing can be effective. And leg crossing, there's actually some evidence from RCTs now to support. Once again, fludrocortisone midodrine can be tried. Small trials show that paroxetine may be effective. And in those that have the bradycardic or cardioinhibitory response, permanent pacing may cure them of their symptoms. But that's very, very unusual. And most patients, I'd have to say, the first two measures are often enough, particularly withdrawing antihypertensive medication, to cure them of the problem. Now, what about carotid sinus syndrome? Well, this is a relatively rare condition. It does get more common as people age, and it's associated with other cardiovascular and cerebrovascular disease. And in this condition, what the patient describes is that they suddenly pass out, either when they turn their head briskly, or sometimes in men with shaving, or if they're wearing a tight collar, that will make matters worse. Now, it used to be called carotid sinus sensitivity because it was believed that the pathology actually lay within the carotid sinus, but we now know it's probably more an abnormality, a baroreflex gain within the brainstem. And this is diagnosed by carotid sinus massage. And how you do that is that you locate the carotid pulse, and you then rub longitudinally up and down for 6 seconds. Before you start, you should check that the patient does not have a carotid bruit, because the main complication of this, albeit rarely, is a TIA or stroke. So never do it in someone with a carotid bruit. And you should also be careful in people who've had a recent cardiac event, be that a serious arrhythmia or MI of some kind. And what you are looking for in response to the carotid sinus massage is this 3-second pause on the ECG. Quite alarming when you do this for the first time, but rest assured, the minute you stop rubbing on the neck, the pulse will return. This condition is cured by a permanent pacemaker, and as you've seen, that's in fact been shown to be effective in preventing falls in people who have carotid sinus massage as the cause of their fall. So I've just given you a lot of information about a lot of different conditions. How on earth do you sort them all out, one from the other? Well, the best approach is to start off by asking the patient what triggers their symptoms, because this will narrow it down at once. If they describe a prolonged period of standing, perhaps in a warm room with other people, I have to say in Scotland it's a very common thing to happen to old people at parties or when they're standing in church. You're probably dealing with vasovagal syncope. If their symptoms are occurring on exertion, you must think about cardiac disease. If they have any of the classic provokers of the situational syncopes, as I've said, they're fairly obvious. But if there's any relationship with emotional distress, you also want to think about anxiety as the possible cause. If the symptoms occur after an hour or so after a heavy meal, think about postprandial hypotension. If they occur after standing up, well, they're fairly obviously likely to be postural hypotension. If they occur on head movement and turning, if there's no syncope, it's probably more likely to be cervical osteoarthrosis. But if there's any hint of blackout, you must include carotid sinus syndrome. If there are no triggers at all, the differential lies between a dysrhythmia, most likely, and anxiety. The next step is to ask about associated symptoms. If they have chest pain, palpitations, you're obviously thinking about a cardiac cause. On the other hand, if they have more in the way of nausea, sweating, blurred vision, you're thinking about one of the neurally mediated syndromes, perhaps a vasovagal syndrome. You also want to ask the patient about any possible exacerbating factors. Is there anything that may be causing them to be volume deplete, such as diuretics, any hemorrhage, Addison's disease? Has alcohol featured anywhere with their symptoms? Are you counselled about reducing their intake? Are they on medications that might have provoked their symptoms, as I've explained before? You want to feel their pulse. Is it regular? You want to listen to their heart, looking for murmurs. And in people who you think may be anxious, and that's the cause of their symptoms, it's worth getting them to voluntarily overbreathe to see if you can reproduce the symptoms. And similarly, those that have symptoms on head turning, it's useful to get them to actually make the moves that cause it, to see again if you can reproduce the symptoms. It's worth just looking at the moment at the prevalence of the different causes of syncope by age, and you'll see at all ages the neurally mediated symptoms, including postural hypertension, are far, far more common at all ages than the cardiac causes. But you will also notice in old age, cardiac causes become very much more common. And it is important not to miss these because they're associated with a much higher mortality than the neurally mediated syndromes. So in terms of investigations, everyone should have a 12-lead ECG, even if you think this could just have been anxiety. Still do the 12-lead ECG because you do not want to miss a cardiac cause. If it's abnormal, you're going to have to investigate things further. Everyone should also have a lying and standing blood pressure simply because postural hypertension is so common in old age and should be addressed. Otherwise, I think you must be much more selective. 24-hour tapes should not be done in everyone with dizziness. I cannot stress that enough. It's a complete waste of time. They should only be done in those with a good history, abnormal ECG, symptoms at rest, or symptoms on exertion. Echoes should only be done really in people with murmurs. And again, I wouldn't indiscriminately do tilt tests and carotid sinus massage in everybody. Certainly if there's any doubt about the vasovagal history, I would consider a tilt test. And certainly if people are having recurrent syncope, I would perform both as well. Synacthin test for Addison's, I would really only do if there was completely unexplained orthostatic hypertension, which is pretty unusual. Most patients are on some drug or another that could explain it. So moving on there to unsteadiness and a favourite holiday snap of my dear father. Obviously, unsteadiness can be caused by anything that upsets the physiological control of balance. And this pathology can occur at any level, at the level of sensory input, so vision or the vestibular system, or indeed proprioception. It can occur at the level of central processing in the brain, or it can occur within the musculoskeletal system, the effector response within the muscles and the joints. Now that makes it sound really complicated, doesn't it? You're thinking, oh my God, how much longer is she going to carry on talking here? But actually, I'm going to tell you my secret quick route into working out why people are unsteady. And that is very simple, just watch them walking. And by that, I don't mean just shuffling about in the clinic room. Open the door, get them to walk right up the corridor and back down and watch very carefully. Because the gait will be abnormal in a very characteristic way depending on the pathology. So I've given you a few examples here. So an antalgic gait, you are thinking about a problem with a lower limb joint. If they walk with a very asymmetric posture, you're considering whether they might have some spinal arthropathy like a scoliosis. If they waddle, Do they have some sort of proximal myopathy? They have a high stepping, stamping gait. They've got a sensory neuropathy. Foot drop will very obviously be either peripheral neuropathy or radiculopathy. If they're ataxic, you're either wondering about sensory ataxia or cerebellar ataxia. If they shuffle and festinate, could they have Parkinson's disease? If they walk with that classic broad base as opposed to the narrow base of Parkinson's disease, marche petit pas, have they got small vessel cerebrovascular disease, hemiplegic gait, people with a cerebral hemisphere lesion, or the very, very unsteady falling backwards. People often can't walk at all with the bilateral hemisphere lesions. So once you've narrowed it down a bit by examining the gait, you can perform a much more focused examination, concentrating on the neurology or the joint and muscle that you think may be the problem, and arrange appropriate investigations and management. And obviously many of these conditions are not amenable to drug therapy, and I think once again improving patients with these problems is very much the domain of physiotherapy with balance and strength training. So now I think we come to the ultimate challenge, the patient with all three at once. Now, I get this sort of letter as a geriatrician quite commonly from general practitioners in Edinburgh. So this is about Joe Normal. Thank you for seeing this 82-year-old man who complains of long-standing dizziness, which has recently become much more severe. He feels unsteady most of the time, but there are also times when he feels lightheaded, and this is so severe that he has to hold on to the furniture to stop himself falling. He has a history of type 2 diabetes, hypertension and osteoarthrosis, and his medication includes lisinopril, metformin, aspirin, simvastatin and cocodamol. On examination, his gait was very unsteady and he would have fallen if I had not. Where do you start? Clearly there are multiple comorbidities, multiple risk factors, there are medications that could be contributing. You think this is going to take me an hour and a half, but no, I have a trick for you. The trick is to take an extremely structured approach, and this is the step-by-step Doctor College guide to sorting out your difficult dizzy patient. Number one, a good history. Use the categories I've described. Is this vertigo? Is this lightheadedness or unsteadiness? What's the predominant symptom? If there's more than one, don't panic. What provokes the symptoms? Is it postural change, head, neck movement, spontaneous? What associated symptoms has Mr. Normal got? Has he had any blackouts? Has he any hearing loss or tinnitus? Has he fallen as a result of his symptoms? And very importantly, what drugs is he on? Now that will immediately allow you to screen out the people that are going to need cardiovascular investigations, because anyone with syncope is going to fall into that category. The vertigo causes, the unsteady causes I've mentioned, don't cause syncope, so you're looking at cardiovascular disease. Anyone with vertigo and hearing loss and tinnitus, immediately you're thinking in terms of the possibility of Meniere's disease and want to refer them on for an otological assessment. So you've already dealt with two big groups there. Step two, examination. You're obviously going to have to do a thorough examination, particularly concentrating on cardiovascular system, neurology, musculoskeletal system, and then you want to try, if you can, to reproduce the symptoms the patient is describing to you. And I've already mentioned a few things, but can you reproduce the symptoms during the rectal and supine blood pressure, suggesting postural hypertension? Mentioned already the importance of looking at their gait. Check their vision. Poor vision is a very common comorbidity in people with poor balance and will make it much worse. Try getting them through the vigorous head and neck movement. If they have vertigo, do a Hall-Pike test. And if it's not at all clear what's causing the problem, do try getting the patient to hyperventilate again, see if you can overbreathe, you can reproduce the symptoms. Now, there will be some after all this that you can't identify a specific diagnosis and you will have to go on to further investigation. But believe me, the numbers left after you've done all this are very small. And as I say, a thorough examination will allow you to find a cause and give your patient an explanation for their symptoms there and then. And that reassurance is a very powerful tool and is often the beginning of a patient beginning to feel better from the outset. So what about treatment in these patients? Well, clearly you're going to have a multi-pronged attack. Any specific disorders you find, I've listed a few there, you're going to need to specifically treat. And I'm not going to go through all these treatments again, perhaps just to emphasize the importance of physiotherapy for the cerebrovascular disease and cervical OA once again. But also reviewing medication, I can't stress enough that I must admit sometimes when I'm not terribly sure whether somebody has cerebrovascular disease or vasovagal symptoms, I will cut back their drugs and refer them for physiotherapy at the same time. Antihypertensives in particular, I'm well worth trying to trim back, if not stop. Correcting people's vision, actively managing their anxiety is also extremely helpful. So to sum up, the aim of my talk was obviously to give you a practical approach to the common causes for dizziness. I haven't mentioned many rare and exotic pathologies, but in honesty, you'll very rarely see them. And as I say, you'll serve your patients very much better if you have a good working knowledge and structured approach to the common causes. Thank you very much.
Thank you very much, Professor Nicola, for a most delightful lecture. Before I throw this paper open to questions, I would like to thank two people. One, my teacher, Professor Krishnamurthy Srinivas, who is responsible in many ways for what I am today, number one. And two, his distinguished son, E.S. Krishnamurthy, who is following in his father's footsteps. And again, before I hand over the mic to my colleague, I'd like to ask you one question myself. Lord Brain, several years back, I think you did mention it, spoke about the narrowing of the foramina and the foramina through which the vertebral artery pass. And they said that there was a narrowing of this foramina which was responsible for a vertebro-basilar insufficiency. Unfortunately, this theory did not stand the test of time and it was questioned. What is your current opinion about this? You did mention it.
Yes, I think
I would like a further detail there.
I guess clearly we have the advantage now of MR angiography, yes, where we can actually demonstrate the flow in the vertebrobasilar system. And studies have shown that if you look at a group of normal older people and compare their findings to those of dizzy older people, you can't discriminate. Those with no symptoms may have narrowing within the system and yet have no symptoms. So I think most people now think the vertebrobasilar ischemia is probably not a real phenomenon, and that possibly cervical osteoarthrosis explains some of them. And it's also possible that it may represent small vessel disease within the brainstem, which is very difficult, obviously, to treat. But that may be a more likely cause of small vessel disease rather than the larger vessel disease that may be at the back of it.
Thank you very much. I hand over the mic to my colleague, Professor Muttarasu, and also throw the paper open for discussion.
Thank you, Dr. Nikki College, for the elaborate deliberation on fainting held. It's very nice to hear you are elaborate almost all the important causes, and it is very nice and excellent lecture. Now the paper is open for questions.
Thank you for excellent deliberation. I have you explained about Hall-Pike and Epley manual. Which one you put in the practice? Because it seems Epley manual seems to be very cumbersome. 4 types, is it not?
The
maneuver? 1, 2, 3, 4.
I don't think it's. It isn't very.
Which one you prefer, Hall Pike or?
Well, it's not a question of preference, in that the Hall Pike you use to diagnose the condition, and the Epley manoeuvres are to treat the condition. I'm sorry if I've made it look cumbersome, because in fact it's very easy to do. Perhaps a little more challenging in very elderly and very frail patients. But I have to say, on the whole, most tolerate it extremely well, and don't find it unduly difficult. The Hall Pike test is obviously done quite quickly, and you're lowering the patient back and then sitting them up again, and you may have to kind of slow it down a little if you've got a very frail patient. The Epley manoeuvres do not happen at speed, so it's actually better to take your time, lie the patient back, wait for a while, and then simply turning their head isn't too traumatic. And perhaps the most difficult one is to get them to lie on their side with their head still facing the floor, or face still facing the floor. But as I say, if you're patient and you have a good nurse with you, it's usually fairly straightforward. And I'm sorry if I've made it look cumbersome, because in reality it's not that bad at all.
2,500 scan for CPA.
Pardon?
And CPA. You said 2,000 exposure to 2,500 scans to diagnose one CPA.
Oh, the CPA lesions.
Yeah.